Welcome to The Critical Edge, the no-nonsense podcast, breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
It's great to be here.
Yeah, glad you could make it. I mean, imagine the scenario, right? You have just pulled off a miraculous damage control laparotomy. The patient came in exsanguinating from a gunshot wound to the abdomen.
The absolute classic Friday night nightmare.
Exactly. So you pack the liver, you leave the bowel in discontinuity, you throw on an apotherovac, and you somehow get them to the surgical intensive care unit alive.
Which is a massive win in itself.
Right. But then, fast forward 3 weeks, the bleeding is long stopped, the abdomen is closed, but the patient codes and dies.
Yeah, and the family is devastated, the team is confused.
Exactly. And why did it happen? Because the prolonged NPO status, the continuous maintenance fluids, and the delayed, inadequate tube feeds effectively starved their gut.
Yeah, obliterated their mucosal immunity.
Right. And it locked them into this catabolic death spiral that they simply couldn't survive. We save them with steel and suture in the trauma bay, but we so often lose them to starvation in the SICU.
It really is the silent killer of the surgical intensive care unit. And that's exactly why we are pulling our insights today from this incredibly dense, just definitive chapter titled Clinical Strategies for Perioperative and Post-Injury Nutritional Support by Jennifer Laub and Patricia M. Byers.
Yeah, it's a fantastic text.
It really forces a complete paradigm shift. It takes the old textbook concepts of surgical nutrition and aggressively updates them with the reality of modern critical care guidelines from the Society of Critical Care Medicine and ACE-PEN.
And our mission today for this deep dive is to speak directly to you, the trauma and surgical critical care surgeons who are out there fighting this catabolic cascade every single day.
Because it is a daily fight.
It really is. So we're going to bridge the gap between basic physiology and advanced application. We're going to tease out how the historic Leuven trials on glycemic control, which we all remember, might have inadvertently caused global harm by ignoring the realities of underfeeding.
That part is just mind-blowing when you really dig into the methodology.
Oh, absolutely. We're also going to dissect a rapidly emerging phenotype known as the persistent inflammatory catabolic syndrome, or PICS.
Right. Identifying PICS early could literally pull your most debilitated chronic patients back from the brink.
Okay, let's unpack this. Before we can even start debating polymeric formulas or TPN, we really have to look at the cellular battlefield.
Microenvironment. Yeah.
Exactly. Because the very second your patient sustains a massive injury, or the moment you make that massive midline incision for a complex laparotomy, this profound physiologic shift occurs.
It's an immediate, basically catastrophic reprogramming of the body's entire fuel economy. We are talking about the acute phase reaction.
Right, the body goes into survival mode.
Exactly. When tissue is injured or when you have massive reperfusion injury following hemorrhagic shock, the neuroendocrine system essentially panics. You get this massive, completely uncoordinated surge of catecholamines, cortisol, and glucagon.
And the purpose of that hormonal storm is singular, right? To mobilize energy substrates immediately.
Yeah, but it does so at a terrible cost to the host's long-term viability.
And the mechanism here is what trips up a lot of residents on rounds, I've noticed. They see the blood sugar spike to 250, and they think, well, great, the cells have plenty of glucose.
Oh, we see that every day.
Right. But that hyperglycemia is a total mirage. The cortisol and catecholamines induce massive peripheral insulin resistance.
The insulin receptors on the skeletal muscle are essentially phosphorylated into a deactivated state.
So the glucose is sitting right there in the blood,
Mm-hmm.
but the peripheral tissues are completely locked out from using it.
Exactly. So the body pivots. It perceives starvation despite the hyperglycemia. It rapidly upregulates lipolysis to free up fatty acids, and even more destructively, it ramps up skeletal muscle proteolysis.
It's literally tearing down the scaffolding of the body to harvest amino acids.
Right. And here is the real physiological trap that we miss. You cannot simply shut off this endogenous cannibalism by hanging a bag of D5W.
Because the conversion of those mobilized amino acids, primarily alanine, right?
Yes, alanine mostly. The conversion of those into glucose via hepatic gluconeogenesis is a completely unregulated process during severe stress.
Wow, so it's not suppressed by exogenous glucose infusion at all.
Not at all. The body will just continue to digest its own muscle mass regardless of what the blood sugar level is.
We used to explain this with the cliche of burning the furniture to keep the house warm.
I hate that analogy, honestly.
I do too.
Yeah?
Because it's actually much more targeted than that. It's more like a wartime supply chain. The body is forcibly requisitioning steel from civilian infrastructure, which is the skeletal muscle, to build tanks for the front lines.
And those tanks are the visceral proteins required for immediate survival. That is a much more accurate framework.
Right.
Because the amino acid pool doesn't just empty evenly. The branched chain amino acids like leucine, isoleucine, valine, they are preferentially consumed by the skeletal muscle itself just to maintain basal cellular function in the face of that insulin resistance.
Meanwhile, glutamine, which we normally consider a non-essential amino acid in healthy people, suddenly becomes conditionally essential.
Oh, absolutely vital. The rapidly dividing cells of the intestinal mucosa and the immune system rely almost exclusively on glutamine for metabolic survival.
And in major trauma, those glutamine stores are depleted within, what, hours?
Within hours, yeah. It's
Yeah.
incredibly fast.
And because of this rapid depletion, the liver is just forced into triage mode. The cytokine cascade, specifically interleukin-1, interleukin-6, and TNF-alpha, forces the liver to stop producing transport proteins.
Right. It drops the albumin and starts mass-producing acute phase reactants like C-reactive protein, fibrinogen, and complement factors.
So the body is actively shuttling every available amino acid away from the limbs and the gut and sending them to the lungs, the heart, and the liver.
And if we don't intervene, the patient rapidly develops clinically significant malnutrition. Which brings us to the historical context of all this, which is, frankly, pretty embarrassing for our field.
Oh, it really is. We act like malnutrition is this modern metric created by hospital administrators.
Right, like it's just a box to check.
Yeah.
But the source text pulls up Hiram O. Studley's research from way back in 1936.
1936.
Yeah. Studley was operating on peptic ulcer patients. He published data showing that patients who had lost over 20% of their usual body weight prior to surgery had a 10-fold increase in mortality.
A tenfold increase. I mean, we have known for nearly a century that operating on a severely malnourished patient is essentially a death sentence, yet we still routinely fail to optimize these patients.
And Studley proved that the mortality was reversible if the nutritional deficit was corrected preoperatively.
But fast forward to today, and the Joint Commission mandates nutrition screening within 24 hours of admission. But let's be honest, in the trauma bay or the SICU, those standard floor screening tools are practically useless.
Oh, they're terrible for critical care. The text evaluates the ESPN Nutrition Risk Screening, the NRS 2002.
Right, and it relies heavily on recent weight loss and baseline BMI.
Exactly. So if you attempt to use the NRS 2002 on a patient who just arrived via helicopter after a high-speed motor vehicle collision, you are completely guessing.
The patient is intubated. There is no history at all.
None. Furthermore, they just received 10 liters of crystalloid and blood products during their damage control resuscitation.
So their admission weight is a complete fiction because of third spacing and tissue edema.
A total fiction. That is exactly why intensivists must transition to using the NUTRIC score, developed by Hayland in 2011.
Right, the nutritional risk in critically ill score. And the methodological evolution of this score is fascinating, especially for us practicing in the U.S.
It really is. When Hayland's group first published it, the algorithm included interleukin-6 levels.
And statistically, IL-6 was an incredibly powerful predictor of inflammatory catabolism, right?
Statistically, yes. But practically, it was a total disaster. A scoring system is clinically useless if it relies on a variable that takes 5 days to result.
Because in the vast majority of U.S. hospital systems, IL-6 is a send-out lab.
Exactly. By the time you get the result back, the patient has either recovered or died. So recognizing this huge limitation, the researchers performed a brilliant methodological pivot.
They reran the validation cohorts after dropping IL-6 entirely.
Yeah, and they demonstrated that removing this inflammatory marker did not significantly degrade the C statistic or the predictive validity of the score.
That's amazing. So the modified NUTRIC score relies entirely on data you already have during morning rounds.
Right. Age, Apache 2 score, SOFA score, number of comorbidities, and days from hospital admission to ICU admission.
And a score of 6 or greater identifies a patient who will derive the maximum mortality benefit from aggressive nutritional intervention.
But, you know, even the modified NUTRIC score has a bit of a blind spot when it comes to pure isolated trauma, right?
Oh, definitely. The text highlights a specific trauma care algorithm for this. It points out that for a previously healthy 25-year-old who sustains a massive crush injury, Well, their baseline comorbidities are zero.
Right, and their APACE2 might be artificially low if their vitals are momentarily stabilized in the bay.
Exactly. But their metabolic fire is absolutely raging. In trauma, the injury severity score, the ISS, and their ultimate ICU disposition are 80% to 88% predictive of the need for advanced nutritional intervention.
So the sheer burden of the physical injury just trumps the lack of medical history. If the ISS is over 15 and they require SICU admission, you must assume they are in a state of hypermetabolism.
But recognizing the hypermetabolism is only step one. How do we accurately quantify this specific caloric deficit?
Well, we used to rely heavily on predictive equations like Harris-Benedict or Penn State.
But in the trauma population, those equations are notoriously inaccurate.
They are. The absolute gold standard remains indirect calorimetry. Measuring the patient's resting energy expenditure, or REE, via oxygen consumption and carbon dioxide production.
And here's the clinical pearl from the deep dive that really invalidates how a lot of us were trained. REE is not a static number.
It's highly dynamic.
Right. You can't just consult the dietitian on day one, get an REE, plug it into the electronic medical record, and leave the tube feed rate locked in for the next 3 weeks.
If you do that, you are basically guaranteeing iatrogenic harm. The data from Ye et al., focusing specifically on trauma patients, tracked REE via continuous indirect calorimetry over a 14-day period.
And the dynamic variability is just staggering.
It is. The energy expenditure doesn't peak on day 1. It actually peaks around day 7 post-injury.
Which coincides perfectly with the peak of the systemic inflammatory response and the massive energy requirements of early wound remodeling and collagen synthesis.
Exactly. And then after day 14, the REE begins to decline back toward baseline.
So if you base your 2 weeks eating strategy on a day 1 calorimetry reading, you are going to massively underfeed them during their hypermetabolic peak.
Right when their immune system needs the substrate the most.
So what does this all mean? We understand the catabolic cascade, the unreliability of standard screening, and the dynamic nature of caloric requirements. Let's move from the controlled environment of elective surgery into the post-injury reality.
Okay, let's start with the elective side first.
Sounds good. The text focuses heavily on upper GI malignancies, esophagectomies, gastrectomies, Whipples.
Right, and over 30% of these patients present with profound cachectic protein-calorie malnutrition.
For these specific, severely malnourished elective patients, the clinical recommendation is actually pretty radical.
It is. You intentionally delay the definitive oncologic resection for 7 to 15 days, specifically to administer preoperative parenteral nutrition.
And you target 1.5 to 1.8 grams of protein per kilogram daily. And you push the non-protein calories to 150% of their basal energy expenditure.
And the prospective data is very clear on this. This delay definitively decreases major postoperative complications, specifically anastomotic leaks and fascial dehiscence.
You are literally rebuilding their cellular machinery before you subject them to the surgical stress.
But, and this is a huge but, the text includes a massive flashing warning light here. You absolutely cannot extrapolate this protocol universally.
Right. If I have a well-nourished patient with a colon mass and I delay their surgery for a week to pump them full of preoperative TPN, thinking I'm supercharging their immune system, I am actually harming them.
You are actively increasing their risk of death. Administering aggressive preoperative TPN to well-nourished or even mildly malnourished patients significantly increases infectious complications.
And the mechanism is pretty straightforward, isn't it?
Yeah. TPN forces the liver to process massive amounts of intravenous lipid emulsions, which can severely impair reticuloendothelial function.
It also induces hyperglycemia, which directly paralyzes neutrophil phagocytosis.
Exactly. Preoperative TPN is a highly targeted therapy reserved strictly for the severely malnourished who have failed enteral optimization.
Okay, moving to the acute setting. Massive burns, blunt force trauma, open abdomens. We obviously don't have 15 days to optimize them.
No, the clock is ticking immediately.
The mandate is that high-risk patients need nutritional support initiated within 4 days of the insult. And when we write those orders, we have to stop obsessing over total calories and start obsessing over protein.
Protein is the absolute king of survival in the SICU.
It really is the primary macronutrient that dictates recovery.
Right. A stable, non-stressed adult needs about 0.6 to 0.8 grams of protein per kilogram per day just to maintain nitrogen balance.
But your SICU patient requires double to triple that amount, right? Like
Hmm.
1.5 to 2.0 grams per kilogram
Yeah.
per day.
Yes. And if you place that patient on continuous renal replacement therapy, or CRRT, the requirement jumps again.
Now, this is a classic resident trap. They see acute kidney injury, they see the BUN rising, and their instinct from medical school is to restrict protein to protect the kidneys.
Oh, I spend half my time untraining residents on that exact point. That is nephrology dogma applied inappropriately to critical care.
Because when a patient is on CRRT, the hemofilter is non-selective for small molecules.
Right. Exactly. It literally strips amino acids straight out of the blood compartment and dumps them into the effluent bag. You can lose 10 to 15 grams of pure amino acids a day just to the dialysis circuit.
Wow. Therefore, your protein target jumps to 2.5 grams per kilogram per day.
Right. Acute renal failure in the setting of trauma is a highly catabolic state that demands aggressive protein loading combined with aggressive dialytic clearance of the resulting urea.
So we are pushing massive amounts of protein. But how do you, standing at the bedside, objectively know if the cells are actually utilizing it?
Well, the Joint Commission and Standard Floor protocols still rely heavily on serum albumin.
But the half-life of albumin is roughly 20 days. So if I start high-protein tube feeds on a trauma patient on Monday, and I check an albumin level on Friday, that number tells me absolutely nothing about the efficacy of my intervention.
It only tells you about their nutritional status from 3 weeks ago, combined with their current state of fluid overload.
Exactly. To monitor the acute efficacy of your intervention, you really have to track the short half-life transport proteins.
Right. Transferrin has a half-life of 8.5 days. Prealbumin is 1.3 days. Retinol binding protein is just 0.4 days.
And prealbumin is generally the most accessible and responsive metric we use in the ICU.
It is. However, there is a complex biochemical interaction here that constantly frustrates clinical teams.
Right. What happens when you are delivering the perfect caloric and protein load? The gut is absorbing it, but the prealbumin simply will not rise above 10.
You have to look at the C-reactive protein. You have to look at the systemic inflammation.
Because, as we mentioned earlier, the liver acts like a wartime factory.
Exactly. The cytokines, predominantly IL-6, bind to the hepatocytes and completely alter their genetic transcription.
So they downregulate the mRNA for transport proteins like prealbumin and massively upregulate the transcription of acute phase reactants like CRP.
Therefore, an elevated CRP indicates that the cytokine storm is still raging. As long as that inflammation persists, visceral protein synthesis is suppressed at the genetic level, regardless of how much protein you pour into the stomach.
You cannot feed your way out of an undrained abscess.
Never. You have to take the patient back to the OR, achieve source control, drop the CRP, and only then will the prealbumin begin to reflect your nutritional support.
The mechanism dictates the management. Okay, now let's tackle the route of delivery. The debate between enteral versus parenteral nutrition.
This is such a critical topic.
It is because it dictates far more than just how calories enter the bloodstream. It dictates the survival of the patient's immune system. The deep dive sources are unequivocal on this. The gut is not just a digestive tube.
It is arguably the largest immune organ in the entire body.
Right. The gut-associated lymphoid tissue, or GALT, contains over 70% of the body's entire immune cell population.
And when you deliver enteral nutrition, you are not just providing calories, you are physically stimulating the intestinal mucosa.
Which is vital. This mechanical and chemical stimulation maintains the epithelial tight junctions, the claudins and occludens, that prevent gut flora from crossing into the portal circulation.
Furthermore, enteral feeding stimulates the enterocytes to secrete mucus-rich in IgA, lactoferrin, and lysozyme.
Which are potent, direct inhibitors of microbial overgrowth.
Exactly. If you leave a patient MPO for 5 days while waiting for an ileus to resolve, those villi atrophy. The tight junctions break down.
The bacteria living in the lumen translocate across the dying mucosa, enter the mesenteric lymphatics, and trigger a systemic sepsis cascade.
And the profound clinical takeaway here is that you don't even need to hit your full caloric goals to prevent this.
Right, that is the concept of trophic, or trickle feeding. Delivering as little as 10 to 20 milliliters per hour of an enteral formula is sufficient to preserve mucosal integrity and stimulate kilt function.
Even if the patient has high gastric residuals, even if they cannot tolerate full volume feeds, maintaining that slow drip into the stomach or jejunum provides a massive immunological shield.
The mandate is to initiate this within 12 to 72 hours post-injury. But the specific formulation of that enteral feed matters tremendously, right?
Oh, absolutely. The sources break down polymeric versus monomeric or elemental formulas.
Polymeric formulas contain intact proteins, complex carbohydrates, and long-chain triglycerides. They require a functional pancreas and biliary system to break them down.
While monomeric formulas are predigested, the proteins are broken down into small peptides and free amino acids. We use these when we are feeding past the ligament of Treitz, directly into the jejunum, or in patients with profound malabsorption.
But where the text gets really deep into the biochemistry is the lipid profile of these formulas.
We have to pay intense attention to the fatty acid composition. Standard, cheaper polymeric formulas rely heavily on omega-6 fatty acids, specifically linoleic acid derived from soy or corn oils.
And the biochemical problem there is that omega-6 fatty acids are the direct precursors in the arachidonic acid cascade.
Exactly. When they are metabolized by cyclooxygenase and lipoxygenase enzymes, they produce prostaglandin E2 and leukotriene B4.
Which are highly pro-inflammatory and paradoxically significantly immunosuppressive mediators. They impair T-cell proliferation and macrophage function.
You are essentially feeding the inflammatory fire. That is why the critical care guidelines often prefer formulas enriched with omega-3 fatty acids.
Right, like eicosapentaenoic acid and docosahexaenoic acid from fish oils.
Yeah.
Omega-3s compete for the exact same enzyme pathways, but produce the resolving series of eicosanoids, resolvins, and protectins, which actively dampen the inflammatory response.
The text also highlights medium-chain triglycerides, or MCTs.
Why are MCTs so beneficial in the compromised SICU patient?
MCTs are basically a metabolic shortcut. Long-chain triglycerides require pancreatic lipase for digestion, a bile salts for micelle formation, and the carnitine shuttle to actually enter the mitochondria for beta oxidation.
And in a critically ill patient, all of those systems are impaired.
Exactly. MCTs bypass this entirely. They are absorbed directly across the intestinal mucosa into the portal vein and enter the mitochondria independently of the carnitine shuttle.
Providing a rapid, easily accessible energy source without exacerbating immunosuppression. That's brilliant.
It is. But let's confront the harsh reality of the SICU. We know enteral feeding is vastly superior, but the literature shows that only about 58% of ICU patients actually achieve their prescribed nutritional targets using the enteral route alone.
Because the interruptions are just endless. The patient's made NPO at midnight for a CT scan that doesn't happen until 4 p.m. They go back to the OR for a washout. They develop an ileus.
Right. If you are only hitting half your caloric goals through the tube, the text dictates that total parenteral nutrition, TPN, must be initiated to close the gap if 60% to 80% of goals aren't met within the first week.
We really have to abandon the old surgical dogma
Yeah.
that TPN is a toxic last resort.
We do. Yes, it carries risks of line infections and hepatotoxicity, but the alternative, allowing the patient to accrue a massive caloric debt and spiral into irreversible catabolism, is far worse.
When the gut fails, or when iatrogenic interruptions prevent adequate delivery, targeted parenteral supplementation is a life-saving bridge. And discussing TPN brings us to one of the most controversial and fiercely debated eras in critical care nutrition.
Oh, the Levin trials?
The Levin trials and the concepts of tight glycemic control. For a decade, the absolute dogma in the ICU was to keep the blood sugar clamped between 80 and 110 milligrams per deciliter using intensive, continuous insulin infusions.
And the text provides a rigorous methodological critique of how we got that so wrong. It is perhaps the greatest cautionary tale in modern critical care literature of how single-center data can mislead global practice.
Yeah, let's break that down. The original 2001 Levin trial, led by Vandenberg, demonstrated a significant mortality benefit with very tight glycemic control.
But we have to look at the methodology. That study was conducted in a highly controlled, predominantly elective cardiac surgery ICU, where patients routinely received early aggressive parenteral nutrition.
Right, they were fully fed, so their hyperglycemia was managed tightly, but they had caloric substrate.
But when other institutions, like the investigators in the massive Nice Sugar trial, attempted to replicate this protocol in mixed medical surgical ICUs across the globe, the results were completely disastrous.
Tight glycemic control actually increased mortality. Why? What was the physiological failure?
The failure was decoupling the insulin from the caloric substrate. In those subsequent real-world trials, patients were predominantly fed enterally.
And as we just discussed, enteral feeding in the ICU is frequently interrupted or poorly tolerated.
So these patients were systematically underfed. When you commit to intensive, high-dose insulin therapy in a patient who is severely energy depleted, the insulin forcefully drives whatever glucose is in the blood straight into the peripheral tissues.
The serum glucose plummets, but because there are no glycogen reserves, the brain is suddenly starved of its only fuel source.
Neuroglycopenia. The lethal combination was attempting tight glycemic control while simultaneously underfeeding the patient.
You induce severe, often unrecognized, intracellular hypoglycemia and catastrophic metabolic collapse.
You simply cannot utilize an aggressive anabolic hormone like insulin without providing the building blocks. Today, recognizing that danger, the safe, evidence-based target for blood glucose in the SICU, is a much more permissive 120 to 180.
You're speaking of interventions that look good on paper, but fail in specific populations. Let's talk about immunonutrition.
Right, formulas supplemented with supraphysiologic doses of arginine, omega-3s, RNA, and glutamine.
The text acknowledges that these are highly beneficial for malnourished patients undergoing elective GI cancer surgery. They reduce surgical site infections and decrease length of stay. But there is a massive contraindication in the SICU.
The current recommendation is absolute. Immunonutrition must be explicitly avoided in critically ill patients who are in a state of severe sepsis or septic shock.
Walk us through the mechanism of that failure. Why does arginine, which normally promotes wound healing, suddenly become dangerous in sepsis?
It comes down to nitric oxide production. Arginine is the direct biochemical precursor to nitric oxide, which is a potent vasodilator.
And in a healthy or post-elective surgery patient, enhanced local nitric oxide improves tissue perfusion and macrophage function.
Exactly. But severe sepsis is already characterized by profound, systemic, uncontrolled vasodilation. The cytokine storm upregulates inducible nitric oxide synthase, leading to refractory hypotension.
So if you load a septic patient with enteral arginine, you are providing massive amounts of substrate to that enzyme.
You pour fuel on the vasodilatory fire, exacerbating the profound shock state, worsening organ perfusion, and directly increasing mortality.
Let me push back on a related scenario, something we face constantly on rounds. We're taught from day one of residency that if a patient requires a vasopressor's norepinephrine, vasopressin, you must immediately shut off the tube feeds.
A classic fear of bowel ischemia.
Right. The theory is that the pressors are clamping down on the splanchnic circulation, the gut is underperfused, and if you demand metabolic work from the bowel by feeding it, you will induce non-occlusive mesenteric ischemia and the bowel will necrose. Is that absolute rule still valid?
The literature has evolved significantly, and that absolute rule is now considered outdated, though obviously caution is still required.
So when is it unsafe?
Hemodynamic instability, meaning the patient's mean arterial pressure is dropping despite escalating doses of pressors, is absolutely a contraindication to enteral feeding. The gut is hypoperfused, and feeding it will cause necrosis.
Makes perfect sense.
However, the recent data strongly supports initiating or continuing enteral nutrition in patients who are on stable or de-escalating doses of vasopressors, provided their MAP is adequate and their lactate is clearing.
But, stable or de-escalating is highly subjective depending on which fellow is managing the unit at 2 a.m. How do we objectively quantify that safety window?
The text utilizes the vasoactive inotropic score, or the VIS. It is an objective, calculated formula that quantifies the total amount of pharmacologic cardiovascular support a patient is requiring.
And it assigns specific weights to different agents, right?
Yes. For example, it factors in the dose of dopamine, dobutamine. It multiplies epinephrine and norepinephrine doses by 100 and multiplies vasopressin doses by 10,000.
Wow, okay. So by charting the VIS every hour, the surgical team can graphically visualize the trajectory of the patient's shock.
Exactly. When the VIS peaks and begins a sustained downward trend, it is an objective indicator that the systemic and splanchnic vasoconstriction has relented enough. Splanchnic autoregulation is recovering, and you can safely trial trophic enteral feeding without a high risk of intestinal ischemia.
This is the perfect segue to take these biochemical principles and apply them to the actual bedside. We're going to run through 4 rapid-fire, highly complex clinical scenarios derived directly from the text.
I love this part.
Scenario 1. The open abdomen and the enteroatmospheric fistula. You have performed a massive damage control laparotomy. The bowel is profoundly edematous, so you cannot close the fascia.
Right, you leave it open.
You place a temporary negative pressure dressing, an apatera, over the open viscera. It is pumping out liters of protein-rich peritoneal fluid every 24 hours. The old school thought was to keep them MPO until the abdomen is closed. Do we feed this patient?
Emphatically, yes, you must attempt early enteral feeding. The prospective data demonstrates that delivering early enteral nutrition in the setting of an open abdomen significantly increases the rate of primary fascial closure.
It also reduces the formation of subsequent fistulas and physically maintains intestinal blood flow.
But the metabolic math changes drastically here. You are losing a staggering amount of protein into that negative pressure canister.
And the crucial calculation mandated by the text is this. You must add 2 grams of elemental nitrogen to their daily requirement for every single liter of abdominal fluid lost.
Let's do that math. If they have 3 liters of output, that's 6 extra grams of nitrogen. You multiply that by 6.25 to convert to protein, and you realize you have to deliver nearly 40 extra grams of protein a day just to replace what is being sucked into the dressing.
That's a huge amount. And what happens if the bowel breaks down and they develop an interatmospheric fistula high up in the jejunum?
Yeah.
Everything you feed them from above just pours out into the wound.
If the fistula output is high, you add an additional 1 gram of nitrogen for every 500 milliliters of sickest lost. But more importantly, you have to creatively alter your delivery route.
You map the bowel anatomy fluoroscopically.
Right. If the efferent distal limb of the bowel, the part downstream from the fistula, is healthy and unobstructed, you perform fistulolysis.
Which means you literally place a red rubber catheter or feeding tube directly into the distal scoma of the fistula and feed the downstream bowel.
But you can't just pump standard formula into a distal jejunal limb. It lacks the pancreatic enzymes and bile salts that normally mix with the food in the duodenum. They will develop massive osmotic diarrhea.
Exactly. You must use elemental, completely pre-digested formulas. Furthermore, the most advanced protocols involve collecting the chyme and succus from the proximal fistula output, filtering it, mixing it with the enteral formula, and reinfusing it into the distal limb.
This recycles the patient's own bile salts and digestive enzymes, vastly improving absorption.
You also have to aggressively monitor trace minerals, right? Because that peritoneal fluid and fistula effluent is incredibly rich in vitamins A, C, E, zinc, and copper.
Zinc deficiency alone will completely arrest cellular proliferation and prevent that open abdomen from ever granulating. You must replete these trace minerals continuously.
Brilliant application. Okay, scenario 2. The morbidly obese ICU patient. We see this constantly. A patient with a BMI of 45, multi-system trauma, mechanically ventilated.
Always a challenge.
My residents always want to calculate their caloric needs based on their ideal body weight because they are terrified that if we feed them based on their actual weight of 150 kilos, the massive carbohydrate load will result in lipogenesis.
Driving their respiratory quotient over 1.0?
Exactly, and creating so much CO2 that we will never wean them off the ventilator. But if we restrict their calories, aren't we starving their immune system?
This is a scenario where standard predictive equations fail completely. The text heavily relies on SCCM and ACE-PEN guidelines, which advocate a very specific, seemingly paradoxical strategy for the obese, critically ill patient. Hypocaloric, high-protein support.
You intentionally restrict their total caloric intake to 50% to 70% of their predicted energy needs.
Which usually calculates to a very low 11 to 14 kilocalories per kilogram of their actual body weight. This prevents the hyperglycemia and the massive CO2 production that makes weaning from the vent impossible.
But you decouple the calories from the protein.
Exactly. You intentionally underfeed the carbohydrates and fats, but you provide massive protein support up to 2.5 grams per kilogram of their ideal body weight.
The physiological mechanism here is so elegant. By restricting non-protein calories, you force the body to rely on its own massive endogenous adipose stores for basal energy through lipolysis.
But by simultaneously flooding the system with exogenous amino acids, you provide the building blocks necessary for the liver to synthesize acute phase reactants and for the wounds to heal.
Actively preventing the catabolism of their lean skeletal muscle mass.
Spot on.
Scenario 3, the ECMO patient. Extracorporeal membrane oxygenation. This is the absolute zenith of life support. Whether it's veno-venous ECMO for profound ARD or veno-arterial ECMO for cardiogenic shock.
These patients are just so tenuous, so hemodynamically fragile that the historical instinct was to ignore nutrition entirely until they were decannulated.
And the data shows the devastating result of that instinct. The text notes that ECMO patients are chronically, dangerously underfed, with barely 30% of them hitting their nutritional targets by day 3.
The current recommendation is that once the ECMO circuit is established and their hemodynamics are stabilized, again, relying on the vasoactive inotropic score to ensure splanchnic perfusion is adequate, you should initiate enteral feeding within 12 hours.
The gut mucosa needs protection even when the lungs or heart are bypassed. But there is a massive hidden clinical trap here regarding overfeeding.
You are talking about the hidden calories in the sedation drips.
Yes, patients on ECMO require profound levels of sedation, frequently running on high-dose, continuous infusions of propofol.
And propofol is formulated in a 10% lipid emulsion. That lipid emulsion provides 1.1 kilocalories per milliliter.
So if a patient is receiving 50 milliliters an hour of propofol, they are receiving over 1,300 kilocalories a day of pure intravenous fat.
Furthermore, they are on multiple vasoactive drips mixed in dextrose carrier fluids. If the critical care team does not explicitly calculate the calories coming from the propofol and the IV fluids, and they start full-goal polymeric tube feeds on top of it, the patient will be massively overfed.
And the mechanism of harm there is severe. The liver cannot process that lipid load. They develop rapid hepatic steatosis, profound hypertriglyceridemia, and because they are burning so much fat and excess carbohydrate, their CO2 production skyrockets.
You end up failing the sweep gas parameters on the ECMO circuit simply because you are overfeeding them. You absolutely must subtract the medication calories from the daily nutritional prescription.
It is an edge case mathematical calculation that can completely alter the survival trajectory of an ECMO patient.
It really is.
Let's hit scenario 4. The COVID-19 ARDS patient, though the lessons here apply to any severe ARDS requiring prone positioning. You have a patient paralyzed, proned on their stomach for 16 hours a day to optimize ventilation perfusion matching.
The sheer mechanics of this are a nightmare for nutrition.
Right. When they are face down, the intra-abdominal pressure rises, gastric emptying is severely delayed, and the risk of massive aspiration pneumonia from gastric residual overflow is terrifying. How do we safely feed the prone patient?
You have to fundamentally adjust the mechanics of delivery. You cannot safely run standard, continuous 24-hour gastric feeds in a prone patient with high intra-abdominal pressure.
The protocol highlighted in the text is to transition to highly concentrated, high-calorie, low-volume formulas.
You calculate their entire 24-hour nutritional requirement, and you deliver it via a rapid, targeted infusion during the 8-hour window when the patient is supine for nursing care. You sprint the feeds while they are safely on their back.
And what about the hardware itself? When a patient is face down for 16 hours, the weight of their head rests heavily on the tubes.
That is a critical physical hazard. If you use a standard, rigid, large-bore Salem sump nasogastric tube, the pressure against the nasal mucosa while prone will rapidly cause ischemic necrosis of the nares and the nasal septum.
Which requires plastic surgery reconstruction later.
Exactly. You must emphasize the early transition to soft, flexible, small-bore feeding tubes, ideally positioned post-pylorically in the duodenum or jejunum under fluoroscopic or electromagnetic guidance.
Bypassing the stomach entirely drastically reduces the aspiration risk when they are rotated back onto their stomachs.
Okay, so we have navigated the acute biochemical phase, the trauma bay, the elective OR, and the highly complex mechanical scenarios of ECMO and proning.
But we need to discuss the long tail of critical care. What happens when the patient survives the initial insult, but their SICU stay drags on for 2 weeks, 3 weeks, a month?
The text details a condition that every seasoned intensivist recognizes instantly at the bedside, but we haven't had a formalized name for it until recently.
You were referring to the persistent inflammatory catabolic syndrome, or PICS?
Yes, PICS. This phenotype, formally defined by Gentile and Moore in 2015, represents a devastating, prolonged evolution of multi-system organ failure.
These patients survive the initial hemorrhagic shock. They survive the subsequent bout of ventilator-associated pneumonia or acute sepsis. But instead of recovering, their immune system breaks down.
They transition into a state of chronic, low-grade, inescapable systemic inflammation.
How do you objectively identify it on rounds?
Yeah.
What are the diagnostic criteria separating it from just general prolonged recovery?
The clinical phenotype is distinct. It is usually an elderly patient, typically over 65, who has been in the ICU for more than 14 consecutive days.
Physically, they exhibit ongoing, severe protein catabolism resulting in extreme sarcopenia. They lose so much skeletal muscle mass that they appear essentially skeletal.
And laboratory analysis reveals a persistently elevated C-reactive protein over 150, elevated white blood cell counts, but paradoxically, severe lymphopenia, with total lymphocyte counts dropping below 800.
And that lymphopenia is the hallmark of their immune paralysis. The bone marrow is constantly churning out myeloid-derived suppressor cells, which actively inhibit T-cell function.
So they become functionally immunosuppressed, suffering from recurrent, indolent, low pathogenicity infections like Acinetobacter or Candida.
But the text explains the nutritional mechanism behind their wasting. It's fascinating. It's not just that they aren't absorbing the tube feeds, it's that their skeletal muscle actively refuses to use the nutrition.
It's called profound anabolic resistance.
The anabolic resistance in PICS is driven by three distinct mechanisms, right?
First, splanchnic sequestration. Even if you deliver the perfect ratio of amino acids into the gut, the intestine and the liver trap them.
The liver consumes them to maintain the chronic production of acute phase reactants, preventing the amino acids from ever reaching the peripheral skeletal muscle.
Second, the chronic cytokine exposure induces deep, intractable insulin resistance at the muscle bed.
Third, and most perniciously, the skeletal muscle develops a blunted intracellular signaling response to leucine.
Leucine is the primary branched-chain amino acid that triggers the mTOR pathway to initiate muscle protein synthesis. In PICS, that cellular trigger is literally broken.
You can pour protein into their veins, and their muscles simply will not rebuild. So how do we fight PICS? If the standard nutritional paradigm fails at the cellular level, what is the multimodal attack plan?
It requires a highly coordinated, aggressive approach that borrows heavily from burn trauma protocols. First, you maintain the high-protein nutritional delivery, but you absolutely must pair it with aggressive, daily, mechanical physical therapy.
Even if the patient is intubated and sedated, you must apply continuous passive and active resistance exercises to physically stimulate the mechanoreceptors in the muscle, attempting to bypass the biochemical block.
You also must maintain tight but safe glucose control to force mitigation of the insulin resistance.
And structurally, we have to look at pharmacologic adjuncts to break the catabolism.
The text strongly proposes utilizing anabolic steroids, specifically agents like oxandrolone or testosterone.
By administering exogenous anabolic hormones, you are attempting to artificially override the leucine resistance, directly stimulating the androgen receptors in the muscle to force mRNA transcription for protein synthesis.
Furthermore, there is emerging data on utilizing beta blockers, specifically propranolol.
Just like we do for massive pediatric burns.
Precisely the same mechanism. The chronic catecholamine surge in PICS continuously drives muscle breakdown.
By introducing a non-selective beta blocker like propranolol, you blunt the sympathetic surge at the beta-2 receptors on the skeletal muscle, significantly decreasing the rate of peripheral catabolism and lowering resting energy expenditure.
Now, in our absolute zeal to feed these chronically malnourished, wasted patients, we run headlong into one of the most classic yet sudden and deadly iatrogenic hazards in all of medicine.
Refeeding syndrome.
Yes. We identify a patient who has been starving in the field for weeks, or a severe PICS patient. We start TPN or high-volume enteral feeds, and 24 hours later, they go into sudden cardiac arrest.
Walk us through the exact intracellular biochemistry of that event.
It is entirely driven by the sudden shift from starvation-adapted fat metabolism back to carbohydrate metabolism. When a patient is starved for weeks, their body completely depletes its total body stores of intracellular electrolytes, specifically potassium, magnesium, and phosphorus.
However, their serum blood levels of these electrolytes might look completely normal in the morning lab draw because the body tightly regulates the blood compartment at the expense of the cells.
Furthermore, because they are starving, their baseline insulin levels are nearly zero.
So what happens when we suddenly turn on the tube feeds at 60 milliliters an hour?
You introduce a massive carbohydrate load into the gut. The pancreas responds by secreting a massive physiological spike of insulin.
Insulin's primary job is to drive that new glucose into the cells. But insulin is a one-way cellular turnstile that doesn't just transport glucose. It forcefully drives potassium, magnesium, and phosphorus straight out of the serum and into the intracellular space to facilitate glycolysis.
And the serum levels, which were barely holding on, plummet instantly.
The drop is precipitous. You get profound hypokalemia, hypomagnesemia, and hypophosphatemia. The hypophosphatemia is particularly lethal.
Glycolysis requires the phosphorylation of glucose, the hexokinase step to trap it in the cell. If all the free phosphorus is rapidly consumed, the cells can no longer produce adenosine triphosphate, or ATP.
The diaphragm rapidly depletes its ATP stores, leading to sudden respiratory muscle failure and the inability to wean from the ventilator.
Furthermore, the lack of phosphorus depletes 2,3-DPG in the red blood cells, shifting the oxygen dissociation curve and preventing oxygen delivery to the tissues.
And the sudden drop in potassium and magnesium massively alters the resting membrane action potentials of the myocardial cells, triggering lethal ventricular dysrhythmias and sudden cardiac arrest.
This is exactly why the guidelines mandate that in the severely malnourished, you must initiate feeding incredibly slowly, often starting at 25% to 50% of their calculated goal.
And you must monitor those three specific electrolytes relentlessly, checking them every 6 hours and repleting them intravenously before advancing the feeding rate.
It requires intense vigilance. Now, if we connect this biochemical reality to the bigger picture, providing this highly specific targeted nutrition requires physical hardware.
It requires central lines and surgically placed tubes. And the deep dive spends significant time analyzing the severe technical complications of our access devices.
Let's start with central venous catheters for TPN. There is a deeply ingrained surgical dogma that femoral lines are essentially guaranteed to get infected, covered in enteric flora, and should be avoided at all costs for parenteral nutrition. Does the modern data actually support that fear?
Interestingly, no, it doesn't. The text clarifies that when femoral vein cannulation is performed under full, modern ultrasound-guided sterile precautions, it does not actually have a statistically higher rate of primary catheter-related bloodstream infections compared to internal jugular or subclavian sites.
However, the text emphasizes that the femoral site is still universally discouraged for long-term TPN access. Why?
Because the rate of deep vein thrombosis in the femoral system is extraordinarily high. The mechanical friction of the catheter in the high-flow iliofemoral system triggers a massive thrombotic cascade.
It is the mechanical and thrombotic destruction of the deep venous system that makes it inferior, not necessarily the infectious risk.
What about subclavian lines? Surgeons love them because they are technically elegant, they keep the neck clear for tracheostomies, and they are excellent for long-term tunneled catheters because of the anatomic stability on the chest wall.
But they carry highly unique specific mechanical risks. The text highlights a phenomenon known as pinch-off syndrome.
Yes, pinch-off syndrome. If the percutaneous puncture for the subclavian catheter is placed too medially along the clavicle, the catheter enters the vein just as it passes through the tight anatomical space between the first rib and the clavicle.
Over time, with every breath and every movement of the shoulder, the catheter is physically compressed and sheared between those two bones.
The mechanical fatigue can literally sever the catheter in half, embolizing the distal tip directly into the pulmonary artery, requiring emergent endovascular retrieval.
You must meticulously review the post-placement chest radiograph, specifically looking for any acute narrowing or pinching of the catheter contour as it passes under the clavicular shadow.
And while we were discussing the life-threatening complications of central line placement, there is a specific clinical pearl here regarding air embolisms that every single surgeon and intensivist needs committed to absolute muscle memory.
Imagine you are placing a central line, or exchanging one over a wire. The hub is momentarily open to the atmosphere. The patient, who is breathing spontaneously, takes a deep negative pressure inspiration.
You hear a sucking sound, and suddenly the patient suffers catastrophic hemodynamic collapse, hypoxia, and a machinery-like murmur.
They have sucked a massive air embolus into the right heart, airlocking the pulmonary outflow tract. What is the immediate reflex life-saving maneuver?
Instantly, without a millisecond of hesitation, you place the patient in the Dramp maneuver. You drop the bed into deep Trendelenburg position, head entirely down, and you violently roll the patient onto their left side.
Meaning their right side is up in the left lateral decubitus position. Explain the anatomical physics of why the right side must be up.
It is entirely about the anatomy of the right ventricle. The right ventricular outflow tract, leading to the pulmonary valve, is located anteriorly and slightly to the left.
If the patient is supine, the air bubble naturally floats up into the outflow tract, creating an airlock that completely stops right ventricular ejection. Cardiac output drops to zero.
By putting the patient in deep Trendelenburg and rolling their right side up, the laws of gravity dictate that the air bubble will rise toward the highest point.
In that specific position, the highest point is the apex of the right atrium and the lateral wall of the right ventricle, safely away from the pulmonary valve.
Once the air is trapped there, blood can flow past it, restoring cardiac output. You can then attempt to pass a central venous catheter directly into the right atrium and physically aspirate the air pocket out with a syringe.
It is a terrifying instantaneous complication, but executing that specific positional maneuver immediately will save the patient's life.
Let's move down from the central veins to the abdomen, securing reliable gastrointestinal access. A massive trauma patient often requires months of enteral access long after they are extubated, so we frequently place surgical feeding tubes during our initial laparotomies.
The text issues a very strong, explicit warning about the dangers of surgical J-tube jejunostomies placed directly through the abdominal wall into the lumen of the small bowel.
Direct surgical jejunostomies are technically easy to perform, but they carry a significant, deeply underappreciated risk of catastrophic mechanical and ischemic complications.
First, the fixation of a single loop of mobile jejunum to the anterior abdominal wall creates a focal point for bowel torsion.
The remaining small bowel can easily twist around that adhesion, leading to a closed-loop volvulus. But the metabolic complication is even more terrifying. Non-occlusive mesenteric ischemia, or NOMI.
Walk us through how a feeding tube causes non-occlusive ischemia.
It happens when you initiate high osmolarity. Hypercaloric tube feeds directly into the jejunum of a patient who is still in a state of low splanchnic perfusion. Perhaps they are still on low-dose pressors, or they have poor cardiac output.
The hyperosmolar feed sits in the jejunal lumen and acts as an osmotic sponge, drawing massive amounts of fluid out of the already compromised bowel wall.
Furthermore, the metabolic demand of digesting that feed steals the limited blood supply away from the mucosa. The mucosa literally starves of oxygen while trying to digest the food.
The bowel wall infarcts, turns black, and perforates, all without a single macrovascular clot in the mesenteric artery. And the mortality on that is absolutely staggering.
It is devastating. The text notes that even with early clinical recognition, immediate cessation of feeds, and definitive surgical resection of the dead bowel, non-occlusive intestinal necrosis triggered by general feeding carries a survival rate of only 56%.
To mitigate this immense risk, the authors strongly recommend that whenever anatomically possible, you should prioritize accessing the jejunum via the stomach using long gastrojejunostomy catheters, rather than creating a direct, surgically fixed stoma in the jejunal wall itself.
It reduces the risk of torsion and seems to lower the incidence of NOMI.
This has been a monumental, exhausting deep dive. We have traversed the entire landscape of surgical nutrition.
We started with the intracellular biochemical signaling of the acute phase reaction, the shifting of the hepatic factory, the mathematical physics of open abdomen nitrogen loss, the cellular mechanisms of anabolic resistance in PICS, and finally the mechanical physics of air embolisms in ischemic bowel.
Let's synthesize this massive volume of information. For the trauma and surgical critical care surgeon listening to this on their commute or in the call room, what is the ultimate unifying takeaway?
The overarching theme of this text is that nutrition in the SICU is absolutely not an afterthought. It is not a secondary checkbox to click on the admission order set while you focus on the ventilators and the pressors.
It is a primary, highly complex, biochemically active therapeutic intervention that dictates mortality just as definitively as your surgical source control.
The gold standard remains early, volume-based enteral feeding. The goal is to aggressively protect the gut microbiome, maintain the tight junctions, and preserve gut immune function.
But simultaneously, we must completely abandon the historical dogma that TPN is purely a toxic last resort to be feared and delayed.
When the gut mechanically fails, or when the inevitable enteral interruptions of the SICU prevent us from meeting 60% to 80% of our caloric goals within the first week, early, targeted parenteral supplementation is a vital, life-saving bridge to prevent the irreversible catabolic death spiral.
Furthermore, we have to stop obsessing over total calories and start obsessing over protein. Protein targets must be aggressively pursued, often up to 2.0 or 2.5 grams per kilogram in CRT, and our metabolic targets must be continually dynamically reassessed using objective tools like the modified NUTRIC score and frequent weekly indirect calorimetry.
So how do you apply this to your actual practice tomorrow morning when you are leading rounds in the SICU? The text gives a very clear, actionable mandate. You need to formally audit your own ICU's enteral feeding practices.
Look at the flow sheets. Are your patients actually receiving the total daily volume of nutrition you prescribed? Or are they being effectively starved by well-meaning but uncoordinated NPO at midnight orders for routine non-emergent CT scans or extubation trials that don't end up happening until 4 p.m. the next day?
That specific logistical failure is the most common point of nutritional breakdown in modern U.S. hospitals. You must work with your nursing leadership to adopt strict, volume-based feeding protocols.
If a patient's enteral feeds are held for 6 hours for a procedure, The nursing team shouldn't just turn the pump back on at the previous hourly rate when they return.
The protocol must allow the bedside nurse to independently and safely increase the infusion rate over the subsequent 18 hours to catch up and deliver the entire 24-hour prescribed volume.
We must begin treating the delivery of nutritional volume with the exact same life-or-death diligence and pharmacokinetic precision that we apply to administering broad-spectrum antibiotics or titrating vasoactive drips.
Treat the tube feed like a pressor. If it's paused, the patient's physiological foundation is crumbling. Well, we are going to leave you with one final provocative thought to mull over as you head into the hospital.
We spent a significant amount of time today discussing the GOLT and how standard enteral feeding mechanically maintains gut immunity.
But research into the intestinal microbiome is currently exploding across every discipline of medicine. If the specific bacterial composition of the gut microbiome is as critical to systemic immunity, sepsis survival, and neurological recovery as emerging research overwhelmingly suggests, are we approaching a radical new era in trauma surgery?
It forces you to wonder what the next decade holds. Are we approaching a time where, during a damage control laparotomy, we don't just focus on feeding the patient's human cells?
Exactly. Are we approaching a time where we actively transplant or bioengineer the microbiome via highly specialized living enteral formulas injected directly into the bowel while the abdomen is still open?
Instead of just providing amino acids, are we going to be prescribing personalized, genetically modified bacterial colonies to actively fight off PICS, reverse anabolic resistance, and prevent late-onset sepsis?
Think about the monumental implications of that the next time you blindly order a standard, sterile polymeric formula from the pharmacy.
It changes the entire perspective of our profession. We transition from simply providing inert calories to actively orchestrating and cultivating a microscopic, life-saving ecosystem within the patient's gut. It is undeniably the future frontier of surgical critical care.
It really is, and it's a frontier we will continue to explore. Thank you for joining us on this massive deep dive. Stay sharp, trust the evidence, and we'll see you next time on The Critical Edge.